Thank you so much for that lovely introduction. So, again, I'm Veronica Santini, and I'm so happy to speak with you. I really caught the bug of loving and learning about the disease of Huntington's disease when I was in my fellowship, and I treated over 100 patients during my fellowship, and really got to know and appreciate the disease for what it was. I am, as mentioned, the co-director of our multidisciplinary clinic at Stanford, and I co-direct this clinic with Dr. Sharon Shaw, who's helped to put this talk together with me. Unfortunately, she couldn't be here tonight. So what are you going to expect from this talk? Well, we'll talk a little bit about the historical perspectives, give you an introduction into Huntington's disease, talk about the genetic basis of disease. We'll also talk a little bit about the pathophysiology, but we're going to try and not get too much into that. We'll talk about who gets this disease and where it comes from, what the clinical features are, and finally, we'll talk a little bit about the therapy in different stages of disease. So let's talk about the historical perspectives first. Neurologists love talking about historical perspectives of disease. So what we know that is that Huntington's disease may have been first described by the alchemist Paracelsus in the 16th century. And he termed this, the most prominent feature of the disease, which is a dance-like movement, Chorea naturalis. Then if we head over into the colonies, the American colonies, we know that in the 17th century, the term St. Vitus dance, or that disorder, was used by the English colonists in New York, Connecticut, Massachusetts. And in the 19th century, Johann Lund, in 1860, publishes his first detailed description of this disease. And he actually is one of the first to describe it as being hereditary. Then in 1872, George Huntington wrote his landmark paper about adult onset Huntington's disease. What's interesting about all of this is it's not until the 20th century, so 1959, that poor Johann Lund actually gets a little bit of credit for his observations. So we'll ignore that fact and head to the landmark paper that George Huntington wrote. This is a picture of the gentleman right there. He is actually the father of a son. He is actually the son of a physician, and he spends his days sitting on outside of his father's office and watching the people walk by. And he notices, through observation, he notices that there are people who have unusual movements. And what he really notes, which is the most important part of his manuscript, is that it's hereditary. And not only is it hereditary, but it hits every single generation in the family. We call that an autosomal dominant pattern of inheritance. We also know that George Huntington was able to describe both the neuropsychiatric features of the disease as well as the cognitive features of the disease. So beyond just talking about the abnormal movements that may come about. And also notably, he notes that there's an elevated risk of suicide in this population, and this is actually the first time that that's described. I'm going to digress just a little bit, and I want to talk to you about something that may not historically be proven, but often is talked about. So in 1692, I think we all know of the famed Salem witch trials, and there is a question in the mind, I think, of many neurologists of whether these movements, along with Huntington's disease, may have been the cause. And so people misinterpreted this and perhaps thought they were possessed by a spirit. And certainly there were no treatments for this kind of disease at that point. So in more recent history, let's fast forward quite a bit, and we're going to go straight to the Lake Maracaibo region of Venezuela. So actually we know in 1955, Amerigo Negrete was able to find this hotspot of Huntington's disease. And this led to the U.S.-Venezuelan Huntington's Disease Collaborative. This is a project that was started under the direction of Nancy Wexler. I'll show you an image of her here. She's here with some of the people in Venezuela in this area who are affected by the disease, and it's actually really been her life's work to learn about the disease, learn about the genetic basis of disease, and help people as much as possible. So Nancy herself is actually quite an interesting woman. She is at risk for Huntington's disease herself, growing up in a home that, I believe, which her father was afflicted with the disorder. And actually, her sister, Alex Wexler, is a famous novelist and wrote a book called Mapping Fate about her upbringing in this environment. In 1983, about 3,000 individuals were genotyped, we say. So we did an analysis of their genome. And through this pedigree analysis, we were able to localize the disease to chromosome 4p. But it was a full decade later before we were actually able to figure out which gene and which area of the gene might be involved. And when we did, we called it Interesting Transcript 15. Scientists are very creative people, as you can tell. This was actually a very paramount finding because it was the first autosomal dominant gene to be identified in this way through these genetic linking studies. Now we know that many diseases can be identified in this way, and it's been quite helpful to further our understanding of genetic diseases, especially in this vein. So our current understanding is that it is an autosomal dominant condition, meaning it does hit every generation, typically of the family. And we know that it's caused by a repeat of 3 proteins in our DNA. There's a certain number of repeats that we can all have, but when it's expanded, we know that that creates an abnormal protein. And we know also that that's on chromosome 4p 16.3, in case you wanted to look in the genome. So what is the exact function of the normal gene? We have no idea. Okay, so this is one barrier to our understanding of the disease itself. We do think it's thought to be crucial for development. And the reason why we think that is when you take a mouse and you knock that gene out completely, so don't have any of those protein repeats, what we find is that the mouse can't survive. And so we think that it's absolutely crucial for development and survival. The other thing that's interesting about this gene product is that it's conserved across species. So when we see something like that that's conserved across species, in general, we believe it must be a very vital and important protein. And so when the gene is expanded, it does lead to a protein that folds in an abnormal way and then becomes basically a substrate to be cleaved, and all kinds of toxic fragments may build up. We don't exactly know why this happens, but our thoughts are when the protein is abnormal, we may have difficulty the cell may have difficulty interacting with other cells and also within the cell. It's interesting because this protein is actually expressed in every single cell of the body. So in the testes, in the brain, in other tissues as well. But we know that it leads to brain cell death in a certain area of the brain that we call the striatum. And most importantly, and something I really want you to keep in mind as we talk about this disease, is that it has a clinical triad. What that means is that there are features of the disease that most people have. So it is, number one, usually a movement disorder. So people have abnormal involuntary movements or have difficulty moving. In addition, it is a cognitive disorder. What do I mean by that? Well, people have difficulty with memory and with thinking. And also it's a psychiatric disorder. So many people have difficulty with psychiatric disease as well. And often that precedes the motor symptoms. So let's talk a little bit about the genetic basis of disease. So I think this is a very helpful chart. And what you can see here is that if there are more than 40, I don't know why this isn't working. If there are more than 40 repeats of that triplet protein, then we know that the person will develop disease. That's a definite. For people who have less than 26 repeats, CAG repeats, we know that they're not at risk of development of disease. So those are our two absolutes in this chart. But let's spend a little bit more time on those middle ranges. So from 36 to 39, we know that there's an inverse length-dependent correlation with development of disease. So what does that mean? That's a lot of words. Who knows what that means? What it means is that the more repeats you have, the higher probability you have of developing this disease. So for instance, somebody with 36 repeats has less of a chance of developing the disease than somebody with 39 repeats. Now let's head over to the what we call the intermediate alleles. So these are repeats within the 27 to 35 range, and these are also called normal mutable alleles. We think that individuals in this range do not develop disease. However, there are a number of case reports in the literature, so there are a number of patient reports that actually show that the patient had symptoms, and unfortunately when they passed away we were able to study their brain and see the pathologic markers of disease. And so we do have confirmation that people within this range may develop disease characteristics. In addition, we believe that people within this range may actually have behavioral abnormalities, psychiatric manifestations of the disease. Furthermore, and this is probably the most common scenario, that people in this range don't develop disease. However, when a father transmits, usually a father, but when a father is able to transmit this number of repeats within this range, he may pass it on to his children. And so we know that people who have this range of CAG repeats may actually pass it on to their children. Okay, so what is the age of onset of disease? Well, it's really difficult to determine. And the reason it's difficult to determine is because most studies have difficulty identifying what the age of onset is. So many studies will say the age of onset is the time that somebody develops motor symptoms. And oftentimes, that is the time where somebody's going to come to the doctor's office. So it might be the first time it's identified. We also know that behavioral and psychiatric manifestations of the disease actually may come before that. And so because of that, we're not exactly sure what the age of onset of disease is. But in our mind, we think that the CAG, and in fact we can prove this, that the CAG repeat length actually, the longer the length of the repeat, the younger age of onset you may develop symptoms of the disease. We know that the most severe juvenile forms of the disease can be with greater than 60 repeats. And we also know that the number of repeats can also correlate to late-stage outcomes. And what I mean by that is time in which a person may need to go to a nursing home or may need to get a gastric tube to feed. But that doesn't tell us everything about the age of onset, and so we think that there's also modifier genes and environment that may make a difference as well. All right, so now let's talk epidemiology. We're just going to talk about who gets this disease, where do we find it? Well, it's rare. It's a rare disease. We know that, but it's found worldwide. And the age of onset is typically between the 30s and the 50s. Definitely, we see older and younger onset forms. I unfortunately diagnosed someone recently in their 70s with this disease. So we know that it can be a very broad range. We also know that about 90% or more is inherited from someone. But there's also this percentage of people who may have spontaneous mutations. And we'll get back to that actually. So the prevalence, we know that it's only about 5 to 10 of 100,000 people get this disease. And we know that that is in Western Europe and in Canada, but there's much higher rates in places like we've already talked about, like Venezuela, also in Tasmania, the northeast of England, and in Scotland. And this comment here, maybe it's a founder effect. So some of these areas, we think perhaps that somebody with the gene or carrying the gene traveled to that area, and then that's how the hotspot was created. And then people in that area maybe didn't travel very much outside. We know that the lowest the lowest prevalence of this disease is in African blacks, which is interesting because juvenile Huntington's disease is actually 2 to 4 times higher in African blacks than in white. So it's an unusual correlation that in adult onset Huntington's disease, very low rates in African blacks, but quite high for juvenile Huntington's disease. And the reason for that is unknown currently. But we do know that there's no difference between the number of repeats or the age of onset between different ethnicities. So we know that there's not a genetic basis for that as well. So now we're going to get into the symptoms of the disease, the different stages of disease. Hopefully we'll get to talk a little bit about treatments as well. As we go forward, I want you guys to just think about the clinical triad. So remember, a movement disorder, a disorder of the thinking, and a psychiatric or behavioral disorder. So the prodromal stage, this is typically considered a stage where there are no obvious abnormal movements or extra movements. And so, like I said, typically no motor symptoms at this stage. But we do know that some symptoms can come on 15 to 20 years before the motor symptoms. So some of those might be considered the cognitive symptoms of the disease. And usually that is mild executive problems. Mild executive problems. So what I mean by that is people have difficulty with higher level thinking, multi-step tasks, and things like doing your finances, for instance, or even making a cup of coffee. This occurs in about 40% of people, but that increases as you get closer to the diagnosis and the motor onset. We also know that there are psychiatric changes ahead of time as well. So this is just, we know that not only executive systems have difficulty, probably quite a few years before the disease onset or the motor onset, but we also know there was some studies done. And if you look at this, we ask patients basically to learn a list of words and then be able to repeat those words or at least identify them from a list. And we know that this declines as we get closer to the diagnosis. So, even 15 years, 10 years, 5 years before the diagnosis, that is declining. Okay, so moving on, we'll talk a little bit more about the prodromal stage. 7% of, I just told you that people in the prodromal stage don't develop motor symptoms. But what I'll tell you now is that actually 7% of gene carriers may actually develop motor symptoms. And the motor symptoms are subtle, so eye movement abnormalities, something only really your neurologist may pick up. Changes in the walking, and the difficulty with coordination of the hands. There also can be a decreased sense of smell. This is something we see in other neurodegenerative conditions such as Parkinson's disease and Alzheimer's disease as well. People with Huntington's disease in the prodromal stage, so again, no obvious motor symptoms, may have irritability, they may be more sensitive, they may have difficulty with interpersonal relationships, and also at times feel apathetic or as if they don't care. There is very rare but occasional psychosis in this stage of disease as well. And these symptoms can really increase over time until the time of diagnosis. Interestingly, there are 2 peaks in the suicide rate. The first peak in the suicide rate is right before the diagnosis. And we believe that patients may feel something is abnormal, feel like something is wrong, not be able to necessarily identify that. And very interestingly, right after the diagnosis, the suicide rate drops fairly dramatically. So is it comforting to get a diagnosis and know what's going on? Perhaps. So are there any signs that we can learn about? Is there anything we can identify maybe we can use earlier without genetic testing? Well, a lot of people have looked at the MRIs And what we can see here is there is a lot of brain tissue right around here. This is what we call the head of the caudate. However, in a patient with Huntington's disease, even in the prodromal stage, we may see that this area is much, much thinner. So it is a possible thing to take a look at. And these changes can happen sometimes 16 to 20 years before the diagnosis. There are also subtle cognitive changes that can happen, or thinking changes. And we wonder if maybe we could identify patients a little bit earlier. Having seen quite a few patients with Huntington's disease, I am not sure that the MRI findings are going to be something that we can really hang our hat on. They are present sometimes, not always present, and it's hard to choose an earlier diagnosis stage. So now let's move on to early stage Huntington's disease. This is generally when we think about the involuntary movements starting. So early motor signs of Huntington's disease are chorea. Chorea is a dance-like movement that is continuous, irregular, unpredictable, and flows from one body part to the other. It can sometimes be confused when it's just very early stages as being a little bit fidgety, a little bit restless, maybe a little agitated. And also, people can suppress the movements for a short period of time often. And in addition, movements often flow into a purposeful movement. So maybe there's a little movement, and then it flows into a purposeful movement that the person wanted to do. And so sometimes it can be confused with voluntary movements. Or it can be confused with the person trying to hide the movement. In reality, it's just flowing into a purposeful action. Many patients are not aware of this movement. And so not only in Huntington's disease, but often in other diseases, chorea, for some reason, is something that patients oftentimes are unaware of. And it doesn't bother them. But that is obviously not the case for everybody. So we also know that this can cause incoordination, this can cause difficulty walking, and it can also cause changes in facial expressions. We often think of a characteristic eyebrow raising that we see in Huntington's disease. There's also early changes in mood, similar to what we've talked about: anxiety, depression, irritability, apathy, impulsivity. So that's a big one. And we think that it contributes to the elevated suicide rate. Also, people can have obsessions and compulsions. There's also early cognitive changes. So people can have memory loss, and again, that executive function. So this is a test where we're kind of testing somebody's mental flexibility. We give them a bunch of dots, and we say, connect these dots. And in each square, connect the dots differently. And you can see, although this patient, try as she might, kept connecting the dots the same way. So there's a mental rigidity there. Again, that impulsivity can get people into trouble. There can be trouble with organization and with planning. There's slowed processing speed, so perhaps in a conversation it may take a little bit longer to process. There are working memory problems. What that means is when we take in information, we try and manipulate it and kind of spit it back out. That can be very, very difficult. Attention can be decreased. And also, there's other early symptoms of Huntington's disease. So people can have speech changes. I'm sorry that this slide came out so funny. People can have speech changes. They can also have trouble swallowing. And there's something very characteristic behaviorally that people with Huntington's disease do. Sometimes they quickly put food into the mouth. So shovel food into the mouth and then don't really know what to do with it once it's there. Creates kind of a chipmunk cheek problem. And also there's other non-neurologic symptoms. So muscle atrophy, meaning that the muscles shrink. There can be heart problems. There can be thyroid problems. There can be bone thinning and bone cell problems. And we think this is because the Huntington protein is expressed in every cell of the body. There's also weight loss, and this is something I'm pretty vigilant of in my clinic. It's somewhat unexplained. We think that because the cells of lining the gastrointestinal system are also involved, we think that may have something to do with it. So now we're going to move on to moderate stage disease. And in moderate stage disease, people can have worsening chorea. So chorea is interesting because some people don't have any chorea at all. Some people have chorea just for a short period of time. And some people have chorea that gets worse in moderate stages of disease. I find that interesting because everybody associates this disease with that movement. And certainly that movement can bring people to diagnosis earlier, but it's not always the main feature of disease. Chorea does cause trouble as it gets worse. It can interfere with walking and lead to falls. It can interfere with coordination and disrupt daily activities. And this can be very frustrating. There's also a difficulty with maintaining action. So you see Einstein there sticking his tongue out, having a great time. So one thing that we like to look for is motor impersistence. And what that means is that an action cannot be sustained. So for instance, we test this in the clinic by sticking the tongue out. And I like to count out 1, 2, 3, 4, and go to 10. And see how long the tongue can come out. That can be difficult for multiple reasons, but one of them is this difficulty maintaining action. Also, the speech becomes more difficult, and people can have trouble understanding a patient with Huntington's disease, and that's going to lead to frustration on their part, on the patient's part. And then also, people sometimes notice a faster decline in their motor abilities during this stage of disease. Again, this adds to frustration. So this is, so you can see the picture that patients start to become very frustrated in moderate stages of disease. Their thinking becomes more impaired as well. It interferes with their driving abilities. It can interfere with gainful employment. Psychiatric and behavioral symptoms might also increase. And again, these include irritability, apathy, impulsivity, lack of insight. And then there's poor sleep. And that everybody knows. Poor sleep worsens everything. So worsens your thinking. I don't think I slept very well last night, and I was searching for words all day today. It worsens psychiatric feelings. So if you're feeling depressed, you're probably going to feel more depressed if you haven't gotten good sleep. And it can worsen motor features. And this goes across the board for many, many movement disorders, including Parkinson's disease, tremor, other things. Now, what do you guys think this all leads to? You have a loss of independence, loss of driving, loss of gainful employment, perhaps progression of psychiatric and motor symptoms, and difficulty with speech leading to frustration. So this is where we see the second peak in the suicide rate in moderate stage disease. It's actually 4 times higher than in the general population. Some of the psychiatric literature actually quotes rates as high as 10 times higher than the general population. It is the 3rd leading cause of death in Huntington's disease, and this is a shame. Again, loss of independence, physical independence, increasing frustrations, loss of driving, loss of employment. But there's other things as well, like social isolation and a family history of suicide. Those last 2 factors are actually major risk factors for anybody who commits suicide. And so if you compound that with the disease itself, then you definitely lead to an increased risk. There's also typically many people who have Huntington's disease in their family. They may have grown up with the disease. Perhaps their home life wasn't the best. Sometimes when people suffer from dementia, they can't take care of their children properly, and there can be financial hardships. So this all also leads to increased risk in this population. We're going to move on to advanced stage Huntington's disease. So we see further changes in the motor symptoms. So remember, up until this point, we've basically been talking about too much movement. But what we really find is that in the advanced stages of disease, the movement calms down. Again, this isn't for everybody, but in general, the movement calms down and people develop Parkinsonism. So what's Parkinsonism? Well, it's slowness, stiffness, they can have abnormal muscle contractions. So some people develop teeth grinding, such as you hear sometimes overnight. There can be forceful eye closure at times, and abnormal limb postures as well. And then to make matters worse, all the medicines we've been giving for the chorea, for the extra movements, also cause Parkinsonism. So it's absolutely vital that the clinician, that the physician treating the patients is always thinking about this. Are we making things worse with the medicines we're giving? Walking also worsens. And people develop an inability to maintain upright posture. So remember we talked about the tongue, having difficulty holding the tongue out or maintaining positions. Well, the same can be with maintaining upright posture. And again, this can lead to falls. Increasing falls can therefore lead to serious injury and can even lead to death. We talked a little bit before about causes of death in Huntington's disease, and certainly falls with brain bleeds can be one of those causes, one of the highest causes, in fact. You also have change in the advanced stage of disease. You continue to have changes in the cognition, the thinking, and the behavior. So speech output becomes more and more difficult. The thinking actually can remain kind of at the same progress. So what I often find is that the processing time is quite increased. And so someone with HD just may need a little bit more time to answer you. And so because of the speech problems and the slow processing speed, just give them a second. Let them, they're processing it, they will be able to respond to you. I always assume in the clinic that everybody with HD understands me. And guess what? I follow quite a few patients with advanced stage disease, and I ask them very clear questions. I give them some time, and they give me very appropriate answers back. So it's super important not to assume that delays in response means that somebody doesn't understand you. Also, behavioral symptoms may lessen during these stages of disease, the more advanced stages. So there can be lower rates of suicide and aggression at this stage of disease. The one thing behaviorally that does happen in advanced stage disease, although somewhat rare, is that people can have these episodes of very significant confusion and they may scream or have episodes of screaming. So other bodily functions, so swallowing can worsen, and this may mean that it's unsafe to eat by mouth. And physical dependence on caregivers leads to 24-hour care needed. And this is for their safety. Some people at the very end stage disease may have severe fluctuations in blood pressure and in temperature. Okay, so this is a typical progression that we see. We can see that right before the diagnosis, we have the perhaps the first suicide attempt. Earlier on, we're talking about being at risk or maybe having some positive gene testing before symptoms develop. And then this is all the way down here is where we're talking about long-term care facility or 24-hour care. So let's talk about the therapy. So the general treatment principles that I follow, and I'm not sure why my bullets keep coming up this way, I apologize. The general treatment principles that I follow is to address all aspects of care so that we improve daily functioning. If you're only focusing on one aspect of their care, you're not giving your patients all of the life that they could be leading. Also, I treat medications when they're needed, when people are at risk, if they hurt themselves, but otherwise I don't think we need to over-medicate folks. Nutrition to me is important in absolutely all stages of disease. I don't want to see my patients losing weight. And I don't think anybody should underestimate conservative therapies. So to me, they're vital. Get the physical therapist, the occupational therapist, and the speech therapist involved early on. We also want to utilize our psychiatric services early on and understand that the disease can make it incredibly difficult for a person to take care of themselves. And so caregivers are so very important, even in early stages of disease. So, what else do we know? Well, care should be multidisciplinary, and in general it needs to be. So it requires the caregiver's involvement, a neurologist, and often there are different types of neurologists. I'm a movement disorder specialist. My colleague and co-director, Dr. Sharon Shaw, is a memory disorder specialist. So we often need multiple types of neurologists. We also use genetic counseling. It's very important so that patients understand the implications of getting genetic testing. They understand what the genetic testing means. My clinic would not run the way it does without our amazing social worker. And this is absolutely important, especially because specialized care for Huntington's disease patients is hard to come by. And so really having a Huntington's social worker makes a big difference, as well as our Huntington's nurse, all these conservative therapists, which I heavily utilize. And then it's important to discuss hospice care as well at the right stage, if that's something that a patient would like to consider. So, we unfortunately do not have a cure for this disease, and we don't have anything to slow the progression of disease down yet. We have looked into many, many, many substances at this point. This is not a comprehensive list, but this is a number of things that we've looked into. And unfortunately, we haven't gotten great results. We were hopeful about coenzyme Q10 that showed a trend. And so now we're doing a follow-up study called the 2CARE study to see if it can be helpful. In addition, creatine was studied in the CREST-E study, and unfortunately the study was stopped due to futility. What that means is a data analysis was done, and rather than spending too much money and continuing the study, they realized that the data that they had so far showed that there was no difference. There is a pre-CREST study going on right now looking at the same thing, but unfortunately we think that the results are not going to be much different. So I like to use combination therapies. Okay, so why do I like to use this? Well, why not use one medication to treat multiple aspects of the disease if we can, right? Why expose people to too many medicines if we don't need to? So I really like a medicine called Depakote, or valproic acid. It's an anti-seizure medicine, but it's used for so many other things. And what I like about it is that it's a mood stabilizer. So those mood fluctuations, irritability, labile move, those kinds of things can be well treated with a mood stabilizer such as Depakote. Why else do I like it? It causes Parkinsonism, so that can calm down chorea, and tics as well. We also can use neuroleptic medications. What those are antipsychotic medications. Oftentimes nowadays they're used as antidepressive medicines. And those can be used for the same reasons, mood stabilization and as well as the chorea. I generally find the Depakote a little bit better for the mood stabilization, but I think they both work well. Those neuroleptics, the ones we just talked about, Abilify might be one that you've seen a commercial for on television. These cause weight gain and they work against chorea. So that's wonderful. We want to cause weight gain a lot of times. So I use that for combination therapy. The creatine, could it slow down disease progression? Maybe, but it also causes some weight gain, and it's a great source of protein. And so I say use that as well. And then finally, one of my favorite medications, a very, very old medication called amantadine that works in multiple ways, is the only medication actually that it has very special properties. I like to use it when somebody's complaining about chorea, so the extra movements, it can calm those down. We utilize it in Parkinson's disease for drug-induced chorea. It also helps with Parkinsonism because of its actions with dopamine. And then finally, it gives people a boost. It's a little bit of an energizing medication, and so it can combat fatigue that patients often complain about. We're going to talk briefly about we're going to talk a little bit more about the therapy in early and moderate stages disease. So keep those principles that we just talked about in mind for these next couple of slides. So, what do you guys think? Do we need to treat chorea? I say yes if people are bothered by it. So if they're aware of the chorea, and they're socially embarrassed by it, or it bothers them in some way, yeah, treat the chorea. Why should they be bothered, embarrassed by this? However, that being said, many patients are not embarrassed, are not aware of the chorea, and so if it's a family member that's bothered by the chorea, I don't think that's a good idea to treat. Why give medications that have side effects if the patient's not bothered by it? The other reason that I treat chorea would be if patients are hurting themselves. So if the chorea is making you bang your arms into walls and cause bruises, if you're falling and that can lead to serious injury, it's time to treat the chorea. So what medications do we use? Well, we use the atypical neuroleptics, again, those antipsychotic medications, and these basically block dopamine. These are the ones that have been studied. And probably the one that's been most studied and has the best results is olanzapine, also called Zyprexa. All of these others have been studied as well. I tend to like as gentle of a medication as I can give. I do actually like the aripiprazole quite well. The side effects are that you can get a tardive phenomenon, meaning that a drug-induced movement disorder. You can have Parkinsonism. And there's also a very serious syndrome that people can get called neuroleptic malignant syndrome. So other things that have been studied, again, amantadine. We have level B evidence for this. Riluzole, I'm not sure that I love the evidence for this, but it is level B. I shouldn't say I don't love the evidence for this. Practically, anecdotally in clinic, I find it to be less effective. And memantine has also been studied. Other medications that have somewhat less beneficial effects are the ones listed below. Okay, so now let's move on to tetrabenazine. This is the only FDA-approved medication for Huntington's chorea. It is a dopamine depleter, and what that means is it will not allow dopamine to become more available to the system, and therefore it calms down the movements. So side effects with this medication are dose dependent, and very, very, very importantly, it may increase the risk of depression, particularly during the titration phase of the medicine. So in a population that already has difficulty with depression and may have a preponderance to suicide, you have to be very careful when prescribing this medication and make sure that a patient and family members will be in contact with you, should anything go on. And this medicine can also cause Parkinsonism as well, so important to remember. I think I'm going to just skip ahead a little bit for the sake of time. Here's a nice review of the medications that we use for chorea. And now let's move on to medications for mood. So for depression, the class of medications that's favored is called SSRIs. These are kind of the classic medications we all know about. Prozac is one of them. And also SSRIs can also help with irritability, anxiety it can help a lot with, and sometimes the impulsivity. Again, we talked about the atypical antipsychotics being helpful for mood as well, and then the mood stabilizers such as Depakote. For mania, again, we need to use mood stabilizers here, not antidepressants that can actually worsen mania. So again, valproic acid or Depakote. Keppra can be used as well, and lamotrigine. And, oops, that may just go back. And so we were just talking about apathy. That was on the previous slide. Let me see if I can just go back. There we go. And unfortunately, no clinical trials have actually used this as an endpoint in their studies. So we don't know of any medications right now that work that well on apathy. Interesting thing about apathy. Who does apathy bother? Not the patient. It bothers everyone else around the patient, but not the patient, because they're apathetic. So, medications for thinking. Well, we've looked into a famous medication that we use in Alzheimer's disease called DONEPEZIL. And unfortunately, when this was studied in several small studies, it didn't seem like there was a consistent result. So it seems somewhat variable. And then there was a little bit better open label study, and actually 8 patients dropped out because of side effects. And then there was a 30-patient placebo-controlled study, which means that some people got the pill and some people got placebo. And they actually did not see any improvement in any measures. And what they were looking at there is the UHDRS, which we do in clinic, their functional scores, that is, the MMSC, which is a cognitive score, as well as Stroop and other cognitive testing scores. Rivastigmine is another medication that's used, and this has shown variable results, but this one study in 2007 may have shown some benefit. So what about treating the other symptoms? Well, we're going to treat the speech changes. How are we going to do that? Well, we're going to send patients to speech therapy early and give them the tools on how to properly express themselves. And you're also going to wait for somebody with Huntington's disease to finish. I think our society is always on fast pace, but I think every once in a while we can wait. Also, there's trouble swallowing. So I think a lot of conservative things can really, really help. I like to tell patients mealtime is about mealtime. It is not about chatting. It's not about telling jokes or watching TV. It's about eating food. And so what do we do when we eat? Small bites, put the fork down, and take a sip of water in between. And also using swallowing precautions that we can get from the speech and swallow therapist, and utilizing their diagnostic tests as well to tell us who's having difficulty swallowing. A way you can tell if somebody's having difficulty swallowing is by asking, do you cough or choke when you swallow? Okay. And also, again, this issue of weight loss. So as soon as I see that somebody may be losing weight, it's time for some high-calorie shakes, ice cream, pizza, whatever it is you like. And also, sometimes the medications we use to treat chorea, again, they make you gain weight. So anybody who's unfortunately had to take an atypical antipsychotic medication can sometimes suffer from weight gain. It's a very common side effect of those medicines. All right, so let's move on to the advanced stage disease and what therapies might be available. So this is the stage of disease that I oftentimes think about withdrawal of medication. So a lot of those medicines we've been putting on for the extra movements, it's time for us to reduce those medicines because they give side effects of Parkinsonism. I really like the use of amantadine. I think it's very helpful in this stage of disease, but there are other anti-Parkinsonian meds we can use as well. You have to be careful with these meds because they are dopamine promoting and therefore can lead to behavioral issues as well. So what are the end of life issues? Well, I think these things should be addressed early. I don't think that we need to be afraid of them. I think it should be an ongoing conversation that you have with your doctor. I want to talk to patients when they can talk to me, when they can fully express themselves and tell me what their wishes are. And then I want to readdress it, because guess what? As you go through the course of disease, or as your life circumstances change, as with anybody, your ideas about what you want for end of life may change. I also really like this Aging with Dignity 5 Wishes packet. It goes through several concepts which I think are really, really nice. And is a really nice way for somebody to take a packet home with them and discuss it with their family members in a calm, comfortable environment. You know, it might say things like, if I can't care, you know, at the time of my death, I want my family to know how much I love them. You know, it doesn't even have to cover sometimes, you know, oh, I want the tube, or I don't, or I want CPR, or I don't. We can talk about just things we want with our family. I want to pass away one day at home. So things like this. And then it also addresses the important issues. If I can't eat for myself, do I want to place a tube to eat for me? If I can't breathe for myself and I get an infection, would I want a tube placed for me? Let's talk a little bit about caregiving in Huntington's disease. I think this is an incredibly important issue, so it's worth at least one slide. And basically, we have to understand that there are many emotional and physical demands for taking care of somebody with Huntington's disease. Eventually, 24-hour care is needed. It can be a financial stressor, right? Because there's loss of gainful employment and full-time employment for the patient, as well as the caregiver. So really not a fair situation and very, very stressful. In 2012, we were able to add Huntington's disease to the compassionate allowance listing. And what this does is it expedites disability coverage for patients with Huntington's disease. Caregivers can also apply for caregiver status, and it does provide some compensation. Not a ton, but some compensation is better than none. So I like to really be careful and watch for caregiver burnout. This can happen in any neurologic disease. Many neurodegenerative diseases, people have caregiver burnout. And I can always identify it because usually the caregiver comes to the office and starts yelling at me. And so I say, okay, they're stressed out and I think they're leading to burnout. And that's something we really have to address. So why is that so important to address? Well, we use our social workers to help, absolutely. And it's so important to address because it affects everybody in the house. It affects the caregiver. And if the caregiver doesn't have good health, who's going to take care of the patient? It affects the patient because actually caregiver burnout is very serious and can lead to abuse of the patient. And also, not just physical abuse, but emotional abuse. And certainly nobody wants to live in that situation. So it's our duty to help support the caregivers as well. So I just wanted to thank you. I wanted to put a little plug in. This is my co-director, Dr. Sharon Shaw. You see my picture over there. And this is our entire team. We have an amazing nurse coordinator, Victoria, our genetic counselors, our neuropsychiatrists. We're very lucky in our clinic to have that. As well as our social worker, who's indispensable. There is a Palo Alto support group that is held monthly, and it's, I believe, monthly. And you can contact Andrea Kwan, who can give you more information about that. I just wanted to say one last thing. Neurodegenerative diseases are diseases that are still not understood well. Part of that is because we can't simply just take a piece of the brain and say, what's going on here? And so it's really vital and extremely important that people participate in research and that scientists are interested in answering these questions that are unanswered. It doesn't just take people who have Huntington's disease to participate in research, but we need those normal controls as well, those people to compare them to. So if you have an interest, we certainly would really appreciate it, and I know that it would help further the field. So that's the end of my talk now. I would love to open it up to questions if anybody has any. Yes, please.
Yes, I'm here because a friend of mine has Huntington's, and I was talking to him actually just recently. I saw him last month, and he was talking to me about there's research being done in Great Britain about the genetic manipulations and stuff. Have you heard of that? And if you have, could you comment on it?
So genetic manipulation, as in changing the genome itself?
Yeah, like Genentech, that kind of, but they're doing it in Great Britain.
Yeah, so absolutely. In fact, there's quite a bit of basic science research, and what basic science means is sort of in the absence of the human being themselves. In fact, this can be considered what we call translational research because it's usually taken from a blood sample or swab to obtain the DNA. I think, as far as I know, those studies are still in fairly early stages of development. I think that would be a wonderful treatment if it does come out to be something. So we're hopeful. Things like that, stem cell treatments, these are still in early stages. Actually, stem cells are a little bit more advanced than that. There's a study that's just about to start. I think the pilot study is now closed for recruitment at UC Davis looking at stem cell therapy. Any other questions?
What would be a good place to learn about stem cell therapy and different opportunities around the world?
Yeah, so that's a great question. Where I would start, so the question was, where's a good place to look to learn about stem cell therapies? I am a bit hesitant. I'm a little bit more conservative, but I'm a bit hesitant about going to other countries to get therapies such as that. I think if there's interest in that kind of therapy, joining a clinical trial, for instance, at UC Davis with the amazing Dr. Wheelock, would be a great place to start. This is going to ensure that there's a rigorous scientific process behind it, and I think most importantly, looking at safety. And so we really want to make sure that we're not doing harm just because we're desperate to look for experimental therapies. Does that make sense?
What are the main sources of funding for research in Huntington's?
So that's a great question. One of the main sources of funding comes from the Huntington Study Group. There are some of these study groups in the community, especially for neurologic diseases. And this is a group of scientists, I'm part of that group, who want to be able to explore different therapies and also understand the basis of the disease itself. So I'd say that's a very primary source of funding. There are other sources of funding that come directly from the government as well. And then there are usually smaller pilot programs that some collaborative groups may support. So for instance, Dr. Nancy Wexler, it's escaping my mind right now the name of her organization, but she has an organization on hereditary diseases, and she does give small funding opportunities for that as well. Yes, please.
Could you clarify the time frame of first manifestation?
Absolutely, and yes.
Part two. Do people go all the way to the end, or can, through medication and other therapies, you curtail the development of symptoms at, say, early stage as opposed to progressing to advanced stage?
So that's the questions are twofold. So one is, how long do you have the disease? Is that basically what you're asking? And two is, are there diseases that can help to slow the progression or curtail the disease so that one doesn't progress to advanced stage disease? And unfortunately, that's the holy grail of our research in many neurodegenerative conditions. We want to be able to identify diseases early and stop their progression. Unfortunately, you can see challenges when we don't even really know what the normal protein does. So unfortunately, we just don't have it. And remember that slide, maybe I can pull it up, that slide that I showed you. Let me go back. Oh, it might take a little while. So these are all the things that have been studied. And this isn't even a comprehensive list. So this is absolutely the holy grail in our research. We really want to be able to at minimum, slow disease progression down. Now, how long do people have the disease? Around the time of diagnosis, remember that diagnosis is often the motor symptom starting. But perhaps people have had symptoms before this, for years before. So at the start of the motor symptoms, generally when people get to diagnosis, it's about a 15 to 20-year course of disease. So it is a chronic and progressive disease. Yes?
Other than suicide, are there risks associated with death from the disease itself?
Yes.
What are they?
Yes, absolutely. So sorry I didn't go back to that. I meant to towards the end of life slides. So what we see is one of the main causes of death can be aspiration, meaning swallowing food into the lungs. And that's because of the difficulty with swallowing. And so eventually people usually need feeding tubes if they choose to have them. So I have patients who have decided they absolutely do not want that. I respect that decision 100%. And basically, we have a conversation. I say, right now, there's quite a bit of food going into your lungs. And if it gets into your lungs, you could have a very serious infection that we may have difficulty fighting against. You know, and that's usually when I also may have a conversation about, again, you know, is a breathing tube something you would want? Knowing that perhaps you couldn't get off that breathing tube. So these are very frank conversations to have. And I think patients generally feel relieved that somebody will talk to them about these issues and not keep it as a bottled up secret and something to be, you know, ashamed of. I have many patients who have very different opinions. I have patients who say, I will leave the state and I will utilize physician suicide. I have patients who say, I want to fight with everything I possibly can. So it's a very personal and individualized decision, and I want it to be what the patient wants. Does that answer your question? Okay. And did you have a question?
Yeah, real quick. Regarding sleep,
Yes.
is there anything you recommend for the patients?
So with sleep in general, so neurodegenerative diseases definitely cause sleep issues. And in general, you have to identify exactly what the sleep problem is. Are they having chorea that keeps them up at night? And then you need to treat the chorea. Is it insomnia? Do they get to bed but wake up later? Are they anxious and that's what's keeping them up? So I always think that it's really very, very important to take a very thorough history when it comes to sleep difficulty. Because you can throw a bunch of sedative meds at somebody, but if that's not what the issue is, that they're not going to sleep any better. Does that make sense?
Something like high dose of melatonin.
Oh, so I'm a big fan of melatonin if that's appropriate. But for instance, if it's chorea keeping people up, then we need to treat the chorea. If it's anxiety, then I think maybe it's time to treat that anxiety. Does that make sense? So the question was, with sleep, are there good treatments, good medication options? And there are, but identifying what the sleep disturbance is very important there. Are there any other questions? Okay, so I think that's it. And thank you very much.
Thank you.